So hello and welcome to this emergency medicine podcast on shock. Shock is quite a commonly misconceived and misunderstood emergency, but is actually quite basic as long as you have a way to break it down. During this podcast, I'm going to look at precisely what shock is. Then I'm going to have a look at some of the basic pathophysiology behind it and therefore figure out some of the common causes. And finally, I'm going to look at some basic practical management principles. So first of all, what is shock? Shock basically means an inadequate tissue perfusion of the vital organs. The cause of this inadequate tissue perfusion is usually a persistent low blood pressure. Therefore, clinically the definition is a low blood pressure, that being either a systolic blood pressure less than 90 or a reduction of greater than 30 millimeters of mercury if the patient was previously known to be hypertensive, or altered organ function. For example, confusion or a low urine output. However, it's important to remember that a reduction in blood pressure is actually quite a late sign in shock, and aggressive management of shock should ideally prevent blood pressure falling at all. So, let's have a look at some of the pathophysiological mechanisms behind shock. There are two important equations that you need to know in order to figure out shock. These are that the blood pressure is equal to the cardiac output times the systemic vascular resistance, and that the cardiac output is equal to the heart rate times the stroke volume. As we've already said, shock is really about low blood pressure. So from this we can say that shock must result from either a decrease in cardiac output, such that the heart is unable to produce an adequate output through the ventricle. This is known as cardiogenic shock, may be caused by things such as myocardial infarcts, pulmonary embolisms, tamponades, and valve ruptures. Because cardiac output is low, you tend to get compensation for this low cardiac output with elevation of other indices, such as the heart rate, leading to a tachycardia, and the systemic vascular resistance, leading to cold, clammy peripheries with sweating and pallor. The blood pressure is therefore normal until these mechanisms fail. So the next cause of a low blood pressure is an alteration in the systemic vascular resistance. Common causes of an alteration in systemic vascular resistance are anaphylaxis, sepsis, and spinal shock, where there has been transection of the spinal cord. The last category of causes leading to a low blood pressure are a reduction in stroke volume caused by fluid loss. Common causes are, of course, hemorrhage, which may be into the thorax, abdomen, pelvis, or throughout the entire body, severe diarrhea and vomiting, bowel obstruction, where fluid is sequestered in the gut, and urinary loss, for example, an osmotic diuresis in DKA, or a fluid diuresis of a resolving acute tubular necrosis. So, in summary, there are three groups of things that can cause shock. Alterations in the cardiac output caused by cardiogenic shock, alterations in the systemic vascular resistance caused by anaphylaxis or sepsis, and finally, alterations in the stroke volume caused by fluid loss in whatever form that may be. There is one other important cause to remember that is often overlooked, and this is adrenocortical failure, or an Addisonian crisis. Important markers of this are hyperpigmentation of palmar creases and buccal mucosa. If you want to find out more about Addisonian crises, have a listen to the other emergency podcast on this specific problem. Clinically, the JVP is a useful marker for distinguishing which type or which primary mechanism is occurring to cause a low blood pressure. So, if the JVP is low and there is postural hypotension and cool skin, think about hypovolaemia as the cause. If there is a low JVP together with a bounding pulse and warm skin, think about septic shock or possibly anaphylaxis. If the JVP is high and there are wet lungs, i.e. bibasal crepitations and cool skin, think about cardiogenic shock. As I mentioned earlier, one of the important components of the definition of shock is organ dysfunction. Important follow-ons of shock therefore occur in a number of different organs. For example, cerebral hypoperfusion may lead to confusion and coma. Renal hypoperfusion may lead to cortical necrosis. The heart may be affected, leading to acute heart failure. Pulmonary capillaries may be overloaded, leading to transudation and pulmonary edema. The clotting system may be overwhelmed, leading to disseminated intravascular coagulation. And finally, tissues may become hypoxic and acidotic. So I'm now going to go on to talk about some of the key management principles with regard to shock. Treatment should begin simultaneously with evaluation. The patient must be supported with respect to their fluid balance. It's very important to also establish a cause, as ultimately this severely influences management. In terms of managing this emergency, we can split it into general and specific. In general management, we perform primary survey focusing on ABC. Our aims here would be to maintain a patent airway, give 100% oxygen via a face mask, and to gain access to the circulation with 2 large bore cannulae. In the secondary survey, we want to attach monitoring equipment, do head-to-toe examination. So here, we're going to be monitoring pulse, blood pressure, respiration rate, the temperature, do pulse oximetry, and blood glucose. We're also going to be interested in looking at some specific investigations that will help us to find out what exactly is going on so we can go into specific management. We might, for example, want to find out the central venous pressure by inserting a central line. We want to do an ECG to look for ischemia as a possible cause of cardiogenic shock. We want to do blood gases. We want to do some specific bloods for blood count, urine electrolytes, glucose, CRP, LFTs, lactate, and possibly fibrin degradation products. We need to do various cultures, specifically blood, to see if there's sepsis, and urine for looking for bacteria. We, of course, want to monitor the urine output, and the key figure to remember here is that less than 0.5 mils per kilogram per hour indicates underperfusion of the kidneys. We might also want to do some imaging studies, for example, a chest X-ray, abdominal ultrasound, or CT scan. Finally, we may consider monitoring cardiac output, left atrial and pulmonary pressures via a Schwann-Ganz catheter. The most common cause of shock is probably hypovolemia, and it's useful to stage hypovolemia into one of 4 categories. In stage 1 hypovolemia, where less than 15% of the blood volume has been lost, there is usually compensation via the systemic vascular resistance, so the blood pressure remains normal, the respiratory rate is normal. Patients often, however, have a slight pallor. In stage 2 hypovolemic shock, where 15 to 30% of the blood volume has been lost, the blood pressure is not totally maintained by arterial constriction and elevation of the systemic vascular resistance. Therefore, there is a mild tachycardia with an essentially normal blood pressure, but often with an increased diastolic component and a narrowed pulse pressure. Due to excess sympathetic stimulation, there may also be sweating and mild anxiety. In stage 3 hypovolemic shock, where between 30 and 40% of the blood volume has been lost, systolic blood pressure will fall less than 100 milligrams of mercury, and the classic signs will be present. Therefore, a pulse greater than 120, tachypnea greater than 30, and an altered mental state. In stage 4, which represents advanced shock with greater than 40% of the blood volume lost, there is an extreme tachycardia, a weak pulse, pronounced tachypnea, and a highly depressed blood pressure. The skin is sweaty, cool, and the patient usually extremely pale. So now let's think a little bit about expanding the circulating volume. There are a number of ways or types of therapy that can be given to expand the circulating volume, and I'm going to go through these briefly now. First of all, whole blood can be used, and obviously this is most appropriate in the situation of hemorrhage. If we're not going to use blood, we can use colloid that tends to cause a sustained increase in the plasma volume. Important examples of colloids are gelafusin and Hemocell. This is a useful fluid to use before blood is available in the context of hemorrhage, and is also particularly useful as a volume replacement in anaphylactic and septic shock. Lastly, we could use a crystalloid, for example 5% dextrose or 0.9% saline. It's important to remember that crystalloids redistribute throughout fluid compartments, so large volumes are needed to restore circulating volume. Crystalloids can also cause pulmonary edema, therefore large volumes should be avoided. However, they do have a useful place in volume replacement for diarrhea and vomiting. I'm now going to move on to talk very briefly about some specific treatment strategies for a number of the causes of shock. Septic shock technically is defined as the systemic inflammatory response syndrome accompanied by shock hypotension. Systemic inflammatory response syndrome is greater than or equal to 2 of the following 4 indices. First of which is a temperature greater than 38 or under 36. Second of which is a tachycardia greater than 90. Third, respiratory rate greater than 20 or a PaCO2 less than 4.3. The fourth is a white blood cell count greater than 12 times 10 to the 9 or less than 4 times 10 to the 9. Remember, in septic shock, it's important to do an infection screen. And this includes a chest x-ray, culture of the blood, urine, sputum, lumbar puncture, ultrasound, and possibly CT of chest and abdomen. A wide range of antibiotics are available to obviously treat different types of sepsis, but a good first choice would be IV cefuroxime or gentamicin. Moving on now to anaphylaxis, there's a specific podcast that's available for anaphylaxis under the emergencies, but basically during anaphylaxis you need to think about giving adrenaline and hydrocortisone. Specific dosages are 0.5 ml of 1 in 1,000 of adrenaline and 200 milligrams of hydrocortisone IV. You also want to give an antihistamine, and the one that's usually used is chlorphenamine, 10 milligrams IV. You also need to, of course, maintain blood pressure, and this is usually done using intravenous saline 0.9%, which is titrated against the blood pressure. Also remember, if there are any respiratory symptoms such as wheeze, you can give beta-2 agonists such as salbutamol. Finally, in cardiogenic shock, it may be appropriate to give positive ionotropes. Pharmacological agents that are used here are the catecholamines. The most important catecholamines to be aware of are moderate dose dopamine, usually 5 microgram per kilogram per minute, and dobutamine. Noradrenaline is used as a sympathomimetic in the case of a low systemic vascular resistance, and adrenaline doesn't really have a place in the treatment of cardiogenic shock. So, in summary, shock is defined as inadequate tissue perfusion of vital organs, usually as represented by a persistently low blood pressure, less than 90 systolic, plus altered organ dysfunction. There are 3 important indices that are usually altered and can cause shock: reduction of the cardiac output in cardiogenic shock, reduction in stroke volume caused by fluid loss due to hemorrhage or severe diarrhea and vomiting or urinary losses, and a reduction in systemic vascular resistance caused by anaphylaxis, sepsis, or spinal shock. The JVP is useful clinically for further defining the cause of shock. Basic management principles are to support the patient while trying to establish what the specific cause of their shock is. Remember that specifically hypovolemic shock may be classified into one of 4 stages, and that circulating volume can be replaced using blood, colloid, or crystalloid. So that completes this basic podcast on shock. I hope it's been useful. Thanks for listening.